Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Resa Lewis and Courtney Smalley, both emergency physicians. Their Kevin MD article is Why Point of Care Ultrasound Belongs in Emergency Department Triage. Resa and Courtney, welcome to the show.
Thanks
Thanks
for
for
having us.
having us.
All right. So, Resa, I'm going to ask you to talk about this article for those who didn't get a chance to read it. What's it about?
Thanks for that question. So, people are very familiar that point of care ultrasound is a part of patient care. In fact, it's required for emergency medicine training. What they may not yet be aware is this concept of physician and triage, provider and triage has become a mainstay, specifically crowded emergency departments, crowded waiting rooms, generally large academic hospitals. What's not yet there as a mainstay is point of care ultrasound. And Dr. Smalley, Courtney, and I strongly believe that ultrasound needs to be there just like it's in every other part of the emergency department.
So, Resa, currently, what are some of the conditions or scenarios that you would use point of care ultrasound in today?
Yeah, there are so many. And for listeners who aren't familiar, point of care ultrasound is the same as clinical ultrasound, which is the same as emergency ultrasound. This is a focused patient care, patient safety, diagnostic use and procedural use of ultrasound at the bedside at the point of care. So typically there are yes no questions. In the article, we actually present a case of a young, otherwise healthy patient that is short of breath. And by using the ultrasound in triage, a pneumothorax is diagnosed. Very focused yes no questions that helps us with triaging on acuity because specifically in triage in these emergency departments, patients get an ESI score. We firmly believe that ultrasound can provide a data point and should be used to provide a data point to help with patient safety.
And tell us what an ESI score is.
Dr. Smalley?
Yeah, so this is a score that every patient, when they sign into, comes through the waiting room, they sign in and then they get triaged into acuity. And this ESI score is a 1 through 5 score looking at the sickest patient. An ESI 1 would be a patient that's basically peri-arrest, needs to go right back and maybe even comes in through the back door. Most of our patients that come through the waiting room are going to be an ESI 2 or an ESI 3, meaning they need either urgent or semi-emergent care, but it's not as simple as an ESI 4 or 5, which could be something as simple as like a sprained ankle or a medication refill.
And this score is basically a culmination of chief complaint, the look of the patient. It includes vital signs. So again, we really think that an extra point to help with that ESI determination should be ultrasound.
So, Courtney, you're talking, or you and Risa are talking about ultrasound, of course, in the triage stage, right? So, is that not common? Is that not happening today?
Yeah, that's a great question. So as we've moved in ultrasound across emergency medicine over the years, we have found that ultrasound can be used in almost any environment. And over the years, we've seen ultrasound originally just starting in the trauma bay in a trauma setting where we were looking at sick trauma patients. And that was in conjunction with our trauma surgery colleagues. And that was in the 80s and the 90s and early 2000s. The emergency medicine specialty found that there were many exams that we could utilize at the bedside. And that really brought emergency medicine ultrasound outside of the trauma base and into almost every patient care room in the emergency department. Crowding and boarding has become something, especially in the last 5 years, that is now a much higher topic of conversation amongst emergency medicine physicians as we see that our patients are sicker, there's more patients, our waiting rooms are full. And so what we've noticed is that this transition of bringing the ultrasound to a new environment hasn't necessarily jumped into that environment yet. And so when I've been clinically working, I've been bringing that ultrasound out to triage and saying, why can't we use this here? We can ask a quick yes or no question. We are so skilled as emergency physicians in the setting of bedside ultrasound that many of us can do a quick yes or no exam in under a minute or 2 minutes. And so it really doesn't change the time. We're always stressed about time in the emergency medicine world. Time is very important. We need to move, we need to get to the next patient. But this is something that we are trained to do from the beginning we start our residency training. So we can bring that ultrasound out into triage. And so we are advocating that now is the time to kind of look at this new environment and say, hey, we can bring this handheld ultrasound. We can put an ultrasound in our pocket. I can go from triage room to triage room to triage room with an ultrasound and make diagnoses and help our patients get better care.
And to
So,
be clear, the
mhm.
cart-based units as well, like EKGs are done in triage as well. So it's not even a space occupying technology. And the workflows are built. You're using the same electronic health record, you're typing into the same computer. So actually, completing an examination is the same workflow that physicians would be using in the main parts of emergency departments.
Resa, you talk about a second case about an ectopic pregnancy. So just give us an example of how that point of care ultrasound really modified a risk stratification.
Yeah, and this is sort of a very, very timely case given sort of the current changes that are happening across state by state in our country with abortion law. So patients come to the emergency department. Sometimes pregnancy status is known, sometimes it's unknown. But if someone has lower abdominal pain, with ultrasound, you could put that probe right above the bladder and see whether or not there is free fluid. So the case we talk about is a patient that comes in with lower abdominal pain, which is actually a very common complaint in the emergency department. Her vital signs were stable. She, quote, looked well. But the physician put a probe right above the bladder and saw free fluid in places it should not be. The urine pregnancy test was positive, and within an hour, the specialist, the OBGYN, was called, and she ultimately went to the operating room with a ruptured ectopic pregnancy. Otherwise, someone who looks good with stable vital signs would potentially sit in the waiting room for hours.
Hmm. Courtney, how long does it take for an emergency physician to be proficient in point of care ultrasound?
That's a great question. And so I love the concept of competency and training of our emergency medicine residents. So emergency medicine residency has built-in training for point of care ultrasound. So for the day our residents hit the door on day one, they are automatically on given an ultrasound and said, this is a key part of your training. And we're going to make sure that by the time you finish your 3 or 4 year residency training, that you have done many ultrasounds. The guidelines used to say that the residents had to do about 150 ultrasounds in many modalities before they could graduate. But I would say the current state of our emergency medicine residencies is such that our residents are doing upwards of 400. In fact, we just had a graduation and one resident hit 500 ultrasounds in 3 years. So we are very competent at the bedside. By the time our emergency medicine residents graduate and they go into practice, they are very skilled at making these quick diagnoses, asking the critical questions, and looking for the unstable patients.
And Kevin, just to close the loop on that question, which I agree is an excellent question, like how do you measure competency? The thing about ultrasound, it's not just performing it, but it's also getting images that are interpreted, that ability to interpret the images and then integrate it into patient care. So there's actually a three-step process when training emergency medicine residents. And again, it's not just emergency medicine. Many specialties are using ultrasound, and everybody has the same question. How do you determine competency? It's those
Mhm.
three things: acquiring images, interpreting the image, and then integrating it into the assessment and plan. And so there is a lot of literature in the emergency medicine space talking about number space, like there's a certain number of examinations that need to be acquired for a certain a test. And then there's also that demonstration either by direct observation in the emergency department, an OSCE, or in the simulation space to get those other pieces of the interpretation and the integration.
So it's been a while since I've stepped foot in the emergency department. Courtney, what's the current penetration of point of care ultrasound? How common is it, say, in a typical community setting, community emergency department?
So I would say it's very common, and many of our emergent community emergency physicians are using ultrasound every day at the bedside. The studies that I find our community physicians are using it for is cardiac and lung in that unstable patient that hits the door who's in respiratory distress to make the diagnosis of COPD, CHF, pneumothorax, so many of these critical diagnoses. But we're finding that a lot of our APP colleagues that are working with us side by side in the emergency department are using it for things like abscess IND and cellulitis. So it's very common. Many of our community physicians are using it a couple of times every shift, and it really does augment their patient care.
Anybody who practices with patients that might be considered difficult IV access, perhaps because of diabetes, perhaps because of peripheral vascular disease, ultrasound is used every shift, many times a shift, to assist with ultrasound-guided peripheral IV placement. In addition, our pediatric emergency medicine physicians choose and want to be able to use ultrasound because of the lack of radiation that the modality, has as part of the way it works. But also you can bring it bedside so you don't have to transport patients. And also it saves the radiation, for example, of a chest x-ray. All the patients that might come in with RSV or pneumonia, you can use an ultrasound probe bedside, real time, no radiation, and have answers.
So, Risa, obviously, this article is written because point of care ultrasound isn't used as much as you would like in the triage setting. What are some of the friction points? Why isn't this happening?
Yeah, it's a great question. And, it circles back to like, why now? Why this article? Because we think like, why aren't people like just bringing it? I think sometimes, it doesn't strike people because it's literally often a different physical space. Courtney actually pointed to this concept of like time urgency, like there's no time. I do think people think it takes, quote, a lot of time. And we sort of put forth, we posit that it doesn't take a lot of time. You're not doing 5 different applications, you're doing a focused application based on the chief complaint. And, we start the article by saying, like, no one wants a patient to deteriorate or even die in the emergency department. Physicians don't want it, patients don't want it, patient caregivers don't want it. And so if you have the easy, quick ability to answer that question and get some more data to be like, okay, this patient is okay to sit, for a few more hours. We by no means are making the argument that every single patient is emergent and every single patient needs 20 ultrasound examinations. It's really to help get that focused yes, no question answered so that there is a reassurance like, okay, this person can wait till they're called and there's a bed that's open in the back. It's a patient focused patient safety measure. And back to your question, the pushback is, I think, the concept of time,
Hmm.
the concept of space. I think it just hasn't struck people because they're not used to seeing ultrasound up front. They're used to seeing it in the trauma resuscitation room. They're used to seeing it, wherever people need IVs placed in beds. So I think it's sort of new space. And I think also the provider in triage model is not everywhere, but it's spreading.
Hmm.
And as people are designing, human-centered design is all about bringing the end users to the table. I think in creating these spaces, if you were to bring physicians and residents to the design process of these triage spaces, they would say, we need an ultrasound machine there.
And Risa, you mentioned some of the chief complaints that would warrant a triage point of care ultrasound. Obviously, chest pain, shortness of breath, abdominal pain. What are some other chief complaints that would trigger a point of care ultrasound within a triage setting?
Courtney had a great case that she describes that literally we could all imagine this patient would have sat for hours and really deteriorated. It was a patient that had a high BMI, was obese, and had leg pain, and the leg pain was very high up. So the team was essentially saying, oh, it's probably just a UTI. There was something that went off, a spidey sense for Courtney, and she put the probe over the area that was painful, and it was necrotizing fasciitis.
Hmm. Courtney, give us a sense, if you were to redesign the emergency department from scratch, give us your ideal scenario where point of care ultrasound would be used in triage. Just give us a story or a hypothetical example of how this workflow would be in action.
Yeah, I think you've heard a couple of examples of where we talk about maybe some critical diagnoses that we're making in triage. And I think those are very relevant to the listener. And we all, again, want those patients out of our waiting rooms and into treatment rooms where they can get the care that they need. But some of the ideas that we're starting to explore in as we look into kind of future models of ultrasound and triage is also making those diagnoses. So I'll give you an example. One example would be a patient coming into triage who's got blurry vision
Mhm.
or a curtain in their vision. And I can't tell you how many patients in the last year I have just, as I see the chief complaint is a vision issue, I walk in with my probe, I put the ultrasound on the eye, and I diagnose them with a retinal detachment.
Mm.
So what I do is I walk out and now I just call the eye specialist, and the patient can leave my waiting room and go directly over to the eye center and get the care that they need, as opposed to that consultative service having to come over to the ER to see this patient, or this patient waiting in the waiting room for many, many hours to get back to a treatment area. I can make that diagnosis from the front and start working on their plan of care. And there's a lot of different examples where we can use an example such as this, where we can start thinking about how do we save time for our consultative services? How do we help them triage their time so that we can get those patients to them quicker? And maybe they don't need long length of stays in the emergency department if we can make some of these diagnoses from the front. So these are the things that we're exploring over the next, 6 months as we try to build out, these critical diagnoses, right? You hear pneumothorax, necrotizing fasciitis, but also just general diagnoses that may have some good outcomes for patients and allow them to have a better experience through our emergency department front doors.
More on the business piece, like this is integrated into the electronic health record, the EHR, and it's part of the ultrasound workflow such that when the provider in triage does the examination, those images are saved and they're uploaded. So then they're viewable across the hospital system on PACS. So this is a communication tool. This is a patient care tool. And a note is written. So back to the business case, ultrasound is a codable and billable procedure. And when I say procedure, we're not necessarily doing an ultrasound procedure, just in its diagnosis, it's under a CPT code that is considered, quote, a procedure. Mm-hmm. But this is an examination that can be billed for, and this is a way of making sure it's not just, quote, a waste of time to get extra data, although I don't consider it a waste of time. It is really a patient-focused patient safety measure.
So, Resa, what are some immediate next steps if we want to propagate the use of point-of-care ultrasound in triage setting?
Well, I think my first is to thank you for bringing us on this podcast because we're getting the message out. I think once it's on people's radar, people literally will have that aha, like, oh my gosh, why don't I bring an ultrasound machine when I do my triage shifts? Many of our emergency medicine colleagues are doing triage shifts. It literally is becoming the mainstay of care because of the crowding. And I think it's only going to continue. So publishing on it, writing about it, speaking about it. But I think also there's an element of science. We need numbers. We need data. Courtney and her colleagues have put together a bit of a retrospective chart review looking at cases. And I think the way things progress in terms of getting established, you have the case report, then you have the case series, then you have the retrospective chart review, then you have the prospective convenience sample. I've worked enough in emergency departments in systems. They're like, that's great. That's great. Those of you who are very excited about ultrasound, I think we will have to make the business case to show that we're not adding too much time to that evaluation and triage process. Also that there's a business case. Finally, I'll say I've worked in places where there aren't enough machines. And I think that we need to make sure that the equipment, the devices are available. And with the cost and portability of handhelds, it's going to be more difficult to make the argument that we don't have the machinery available.
We're talking to Resa Lewis and Courtney Smalley. Both are emergency physicians. Today's Kevin MD article is Why Point-of-Care Ultrasound Belongs in Emergency Department Triage. I'm going to end with asking you your take-home messages that you want to leave with the Kevin MD audience. Courtney, why don't you go first?
Great. Thank you, first of all, for having us. I am so excited about bringing this concept into the triage space. And I'm hoping that emergency physicians and other physicians across multiple specialties can see that this can be done in any of these quick settings with the right environment and the right support. We hope that your listeners will consider this, take it away, walk into their environment tomorrow and look at their space and say, yes, I can do this in this space. And so we're excited to potentially move the needle forward.
And Resa, we'll end with you, your take-home messages.
I would say it is never, ever, 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 ever wrong to focus on patients and patient safety. That can be your guiding principle as a healthcare worker, as a physician. Trust your gut and always make it about safe, better, patient-centered care.
Resa and Courtney, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thanks so much for the opportunity.
Thank you, Kevin.